Very good evening to one and all. I will be speaking on OCT angiography. What all can it show us? So we all know that FFA and ICG is the gold standard for imaging the retinal and choroidal vasculature, but it's an invasive procedure. It needs a dye to be injected. It rarely can have serious side effects, and the vasculature is seen as a single layer. And on opposite side we have octa, which uses motion as a contrast to detect blood flow. It's a dye-less, it is quick, has no side effects, it's repeatable. At each and every visit you can do octa, you cannot really do FFA. And it segments the vasculature into the various layers. And these are the various machines that are available. So basically the principle is quite simple. So you do repeated scans are done at one place. So if the tissue is stationary, all the scans are going to look the same. But if the tissue has blood vessels, and in the blood vessel the RBCs are moving, so when the repeated scans are done, it will change because of the movement of the blood vessels. So that is known as, the reflectance will be different. That is known as decorrelation signal. So that is the basic principle. And this, whatever we get resolution images, those are split into low resolution images, and then a average decorrelation is done. This is done by a algorithm that is known as split spectrum amplitude decorrelation algorithm. So this is how it looks. You can see there's a SCP, superficial capillary plexus, deep capillary plexus. Outer retina usually does not have any blood vessels, and this is the choroid capillary. So this is how the octa will give the segmented vasculature. So this is the printout that you get, and you can see the OCT also is there besides it. So you can move the segmentation, you are sure what image you are assessing. So this is one article that we published in 2016. So you should remember that before the patient develops any DR changes on fundoscopy, the octa will pick up changes. So the normal eyes had lower FAZ area, higher vessel density, lower spacing between the large and small vessels. But if you look at the diabetic patients, as the diabetes retinopathy increases or the grade increases, you can see the vessel density is coming down, the vessel gaps are increasing, FAZ also is increasing. So it's a good way to sort of study the diabetic retinopathy, how it progresses. So and the other useful indication could be, here you can see there's a retinal hemorrhage. You are not sure whether there is a new vessel here, but if you get a octa, so you can see the vasculature is very nicely seen. You should concentrate in this area where there is a junction of the ischemia and the normal retina. And then if you do laser, so you can, if you do laser, you can very well see the morphology. If you do FFA, it will just leak. But here you can see how nicely the vasculature has changed, the morphology has changed. It is not very exuberant. The anastomosis, looping has come down, and a few vessels are seen, that's all. So it's very good to study the morphology. And it has very good prognostic value in DME cases. So basically, if there are more microaneurysms in the DCP, that will, patients are going to respond poorly. If there is more edema, they are more likely to have aneurysms in the deep capillary plexus. Similarly, the larger the FAZ, they also may not respond very well. And similarly, in DCP, if you see this area of non-flow, so it usually corresponds to the breaks in the outer plexiform layer. So there is a correlation. And the other useful thing is in the AMD. It is very useful. Studies have shown that it picks up the CNBM very well. So this is one of example. You can see a patient, 68-year-old male, complained of decreased vision since 1 month. You can see there's a NSD here, pockets of IRF, and this is the membrane that is seen. So the octa, you can see how nicely you can pick up the membrane. And this is post-treatment. So you can see the vasculature has come down, the arborization of the vessel is less. So it shows that it is not really leaking. So you can see the change that has happened. And the OCT also, corresponding OCT also shows the same. This is another patient, CNVM. You can see how nicely it is picked up. And this is after 3 injections. So various patterns have been described. Octa in AMD, it can be C-fan type, it can be Medusa type. Here you don't see a distinct membrane, and this is the dead tree pattern. So the other useful thing is pachychoroid neovasculopathy. So Dr. Talwar was talking about chronic CSCR. So basically patients with chronic CSCR can develop CSCR neovasculopathy, that is known as pachychoroid neovasculopathy. So whenever you see a patient with CSCR with a flat irregular PED, you should suspect that you are dealing with neovasculopathy. So studies have shown that in this article, most of the eyes with FIPED had PNV, and similarly, you should not forget that such eyes from neovasculopathy can convert into PCV. It's a spectrum, pachychoroid spectrum. So here is the case. So you can see there's a flat irregular PED. Usually Brooks and RP are seen as one layer, but if there is something growing in between them, it's a separation that is known as flat irregular pigment epithelial detachment that you can see here. So this was a 39-year-old male recurrent CSCR, and OCTA was done, and you can see the vasculature, and such patients have to be treated with anti-VEGFs. And this is after 1 injection, this is after 2 injections, and you can see the change in the tangled vasculature that you have seen. And the other thing is that this is the same, you are seeing a FIPED here, and you don't forget the morphology of the choroidal vessels. Here you can see there's a dilated vessel that is known as Haller vessels. So, and this usually Haller vessels changes in the PED will overlay this. So that also is important. And then you can see the membrane that is so nicely seen. The membranes are mature and they are in one layer. The retinal anatomy is not much distorted. So the OCTA picks up this CNVM in a very nice way. If you see the FFA, it does not really pick up. You just see a sort of leakage of undetermined source, but OCTA is very good to pick PNVs. And similarly in PCV also. So this is PNVs can convert into PCV, and OCTA is quite useful in PCV also. It is very good to pick up the branching vascular network, but polyp sometimes you may not pick it up. So that could be because of the poor flow. It could be located away from the fovea. There could be error in segmentation, and BVN and polyps could lie in different levels also. It could be a little raised. So if it is not segmented properly, you can miss that. And the polyps also can be seen as hyperflow, hypoflow round structures. So here you can see clinically also you can suspect there's a subretinal lesion here, and this is the corresponding OCT, flat irregular PED, SRF is there, and this is the ICG. You see the polyps here, and OCTA also shows the polyps. This is that was the ANFAS OCT, and this is the OCTA. So you can see how nicely the branching vascular network is seen, but the polyps are not really that well picked up. So this is another case. This is the ICG. You can see the BVN here, polyps, and BVN is very well picked by the OCTA, and this dark could be the polyps. It's a sort of hypoflow. And on OCTA it has been described as 3 types of BVN. The major vascular trunk type, it's a BVN that looks like a nephrons, and this is a tangled caliber of vessels. So basically this one has the best prognosis, and these don't really do well. So it tells about the management and the prognostication also. This is another case, one of our cases. You can see the subretinal nodule, how nicely the polyps are seen. And in OCTA you can see this is hypoflux flow structure, this is a hyperflow. And here also BVN you can see in another case. And the other useful information that you can use OCTA is for myopic CNVM. Any patient with myopia who comes with a sudden decrease in vision, you should not take it lightly. Sometimes CNVM can be missed by just doing a fundus photograph or OCT. So here you see the OCT does not really show any too much structural changes. The CNVMs in myopia don't leak too much. You don't really get very profuse structural changes. So if you just based on OCT, you would have said everything is fine, please go. But if you see the FFA, you can see there's a leakage. But every time you cannot do FFA. So OCTA is very good. This myopic CNVMs of type 2, they are above the RP. So it is very well picked up by the OCTA. This is another case. This is subretinal hemorrhage. So subretinal hemorrhage also can be because of Lecker crack, which does not really need any treatment. It can resolve on its own. But FFA shows that there is a CNVM, and this is the OCT. You can see the CNVM, there's a blurred margin, and Octa shows the CNVM in a very nice way. Similarly, this is pre-injection, this is post-injection. You can see the change in morphology, and this is the recurrence at 3 months. So myopia is very useful. Myopic CNVM, Octa is very useful. And the other thing is the MACTEL. So basically in MACTEL, because of the FFA leakage, you don't really get to know what is happening. But the morphology and how the disease progresses, it is well explained by Octa. So we had a publication long time back. So the changes usually start in DCP. There is a dilatation, rarefaction, abnormal communications, and there's temporal enlargement of the FAZ. So Octa can be used to stage the CNVM also. You can do a structural vascular function correlation. So it's very useful in MACTEL also. This is a case, you can see MACTEL, there's an ileum drape sign here, but there is both eyes, there is a PED. So MACTEL can sometimes get complicated by CNVM formation. So FFA can get some idea, but because of the leakage, you don't really appreciate much. But Octa definitely shows there is a neovascularization here, and this patient will need anti-VEGF. This is another interesting case. Patient had a CRAO. So you can see it was a cilioretinal sparing CRAO. Octa showed, and then this is the after paracentesis immediately. So you cannot really keep doing FFA, but Octa can be repeated, and this shows. And this is hypertensive choroidopathy. The choriocapillaries are not autoregulated, thus making them susceptible to severe rise in BP, and it causes hypertensive choroidopathy. So you can see this flow wide areas. This is the left eye, right eye, and this sort of flow wide area damage to the choriocapillaries can damage the RP. So it can be because of the ischemia, and you can get subretinal accumulation. So it is very nice way to study the extent and the impact of malignant hypertension on the body's microcirculation. Because the patients have high BP, you cannot really do FFA in such cases. So to conclude, Octa provides in vivo visualization of retinal blood vessels in a depth resolved fashion. Dye-related complications are avoided. The indications for Octa are gradually increasing, but small area is imaged. But now we have a little better imaging facilities and machines that can give up to 12 by 12 millimeters. But there's definitely a learning curve, and cost and availability as an issue. Thanks for a patient hearing.
Thank you, Dr. Yadav, for a very well-defined lecture, which has made it very clear as to what are the new things which we can see. You know, till 2 decades back, हम आँख को सिर्फ देखते थे, ऑप्थेल्मोस्कोपी करते थे, ठीक है कुछ swelling है, कुछ white है, कुछ point है, कुछ dot है. Today, we are not replacing your clinical acumen with a machine. We are increasing the ability of your eye to see the ultrastructure of the eye. अभी तक हम क्या देखते थे? Gross structure. अब हम देख रहे हैं ultrastructure. Pathology ka ultrastructure. What is happening exactly in which lesion, which disease, and when we treat it, what happens? So we know much more accurately how to treat. It's like now using guided missiles instead of using one big 2,000-pound bomb and saying everything's gone. So, ladies and gentlemen, you have heard a lot today. Are there any questions from you? Anyone has any questions? Please come forward.
I would like to have one question for Dr. Naresh. So sometimes if there is a large PED in the center, so it's very difficult to visualize the BVN under it. So how do you, is there a way to do anything, seek better?
I think it is correct still that Octa cannot really go through the serous-sanguineous PEDs. So sometimes if it is serious, you could still get. But I think it's difficult. The only thing is that sometimes at the edges you could appreciate something. Or if you sit at the machine and try to segment, then you may get. But very large PDs, still I don't think you can get good images.
Yes, because
same thing with the posterior staphloma also. If you have a very high myopia, then in a setting of posterior staphloma, it becomes really difficult. But low myopes and all, it's very good to pick up myopia.